Okay, so this next session is looking at small studies, innovations that may have a future. These are 7-minute presentations. First one is from the Swati Pharmaceutical. Dr. Taneja is presenting the initial observation study on the intravesical treatment. Dr. Taneja.
Thank you, Dr. Badlani, and ladies and gentlemen, have a good morning. This is a small observation group that we created, and this followed the Director General of the Drug Controller General of India approving the solution of for intravesical use of pendazole polysulfate. And we were given vials to look at how to use them and get the initial feedback of feeling of what we get with this molecule. The background, as we've been talking about, is the inflammation and, of course, thinning of the gag layer, and the possibility that if we fill the gag layer again, the pain will reduce and the inflammation would reduce. So what we got was intravesical pendazole solution, 30 ml in 30 milligram, and it was to be instilled directly into the bladder. And obviously, we were targeting the gag layer, and we thought it would reduce the inflammation with minimal symptoms, which is the systemic effects. And of course, a quicker response as compared to the oral one. So we selected patients which were more than 18 years, who could give an informed consent, and they fulfilled the diagnostic criteria for bladder-centric disease or ICBPS. And of course, the exclusion criteria were any history of hypersensitivity or recurrent urinary infections. A cystoscopy was performed under anesthesia as per the diagnostic and therapeutic methodology, which has been published by our group. And we selected our patients based on the bladder-centric disease, which was either the capacity less than 400 under anesthesia, presence of Hunner's lesions, glomerations, and mucosal cracks. And it was a multicentral observation with 8 urologists involved in 4 different cities of India for 12 patients that we had. And it was instilled as per the standard procedure, twice weekly for 8 weeks, along with oral pendazole polysulfate 3 times a day, dietary modifications, and the pre-treatment concomitant symptomatic medications, if any, like urinary alkalizers, amitriptyline, or hydroxyzine. The methodology of intravesical instillation is important because it can cause intense pain when directly instilled into the bladder with this concentration. So we needed to alkalize the urinary bladder after draining it, wait for the soda bicarb solution to act, then added xylocaine solution, the lignocaine, for another 5 minutes, and then drain it off, and then instill 30 ml of the intravesical pendazole polysulfate. And we removed the tube and asked the patient to keep it as far as possible. Although there was no pain anticipated at the time of instillation, but as the effect of lignocaine waned off, they would have some suprapubic pain, and many of our patients required diclofenac 50 milligram, a single dose the same evening, and then the next day morning they were much better. So clinical assessment was done on day 0 and at the end of 8 weeks, according to the Apollo clinical scoring system, which has the domains of bladder pain, urgency, frequency, nocturia, sexual dysfunction, and psychological impact, with a total of 50, a score of 50. And we had 10 female patients with a mean age of 49 years, and they all had symptomatic improvement across all domains. Tolerability was good. As I mentioned, there was pain in some of them in the evenings, the same evening, and 2 of them had gastrointestinal upset, but there were no dropouts. And these are the scores, and you can see that the mean score of ACS fell from 33 to 11 over 8 weeks period. And the greatest improvement was seen in the pain and the nocturia scale. This is the same thing represented as a graph. So obviously, there's very little to discuss because we all know by now that the local action has minimal systematic exposure, and obviously, we were targeting the patients who were nicely phenotyped to bladder-centric disease. It was reasonably well tolerated. As I said, the only thing was pain in the evening, and this highlights the multimodal approach. The shortfalls, of course, are that it is not a well-designed study, but then it is a small population with short follow-up. And then my thoughts about use of lignocaine, because I know that it downregulates the pain receptors. So I am not sure how much is it adding to the pain-free status of these patients, and how much should it be attributed to the intravesical pentosan polysulfate. And of course, role of concomitant medicine can be challenged, but they were already on that medication, so I think that wasn't doing good enough, so we just allowed that to continue. And that perhaps was not adding on enough. So it is in conjunction with the oral PPS and other non-specific medication that we can add intravesical pentosan polysulfate for a rapid relief. These patients have really rapid relief in pain and nocturia, and they would beg. They would call me before the next dose, and they would say, can we have it a little earlier because I'm scared that I will have pain again. So that is the rapidity with which these patients actually responded. And they would look forward to their next dose, despite the fact that they would have some pain which was temporary in the evening. Otherwise, it was very well tolerated. This is a small bibliography. Thank you so much.
Maddie, can you? Our next presentation is an innovative application of a thermal medicine from Zach Lyons. This is a concept. Zach, are you? Yeah.
While they're working on that, I want to just be respectful of time. I want to thank Dr. Evans, Dr. Walker, Dr. Bhavani for inviting me here. This is truly an honor, seriously an honor, to present in front of such an esteemed audience. We're wonderfully made, as is the environment that supports us. Like Curtis' story about the pie recipe, I could not agree more. My wife understands support systems for her flowers in the yard, the soil, the fertilizer, the proper positioning of shade and moisture levels. Because of this knowledge, year after year, we have the best damn yard in the neighborhood. And Dusty Dawn provides thermal cycles in the right order at just the right time, and mostly to promote life, a recipe, if you will. We're all part of that modulating experience, and we're affected by it. When it's out of balance, we also suffer. We talk about the complexity of overlapping etiologies of pelvic pain, the chicken and the egg, and how the root cause might be an unresolved inflammation, rendering a natural system out of balance and causing pain, manifesting itself to resolve in mind-bending pain. Like a drug, too little is not effective. Too much can stop life. Proper balance yields proper results, sometimes with side effects. What if new therapy recipe, a new balance with no side effects to treat crossed up, cross-inhibited pelvic pain states existed? Even go so as far as to say we could treat these out of balance conditions possibly in the safety and the sanctity of one's dignified home environment. What if? Oops. Let's see here. Excuse me. Okay. I just got us out of presentation mode. Present. Okay, there we go. So before I came here, I went out to Claude AI. I love AI. I said, Claude AI, look at Reddit, Facebook, all the user groups of all the people complaining about ISCP BPS and tell me, what are the biggest complaints? Well, you see, symptom management, treatment effectiveness. we got some work to do, so it was quite interesting. And why thermal medicine? I like to say sometimes because you can doesn't mean you should, but if you can, maybe you should. Because we can. So what you see here is quickly are a swine model and a human model of our thermal energy applications. These are in gel phantoms to simulate the performance of both that we correlated. And we did this with an NIH grant with Duke University, by the way. So this is our team who we spent the last year and a half spending many hours, many days with 5 live swines to do this research and the study. What the result was is we were able to confirm that we're able to penetrate deep tissues with simple thermal therapy. Yes, both cooling and warming for various different applications. This poster was presented at the Duke Cure event last month in April to show the results of our initial study. And pig, swine, the swine model, the porcine model, it's quite different than human anatomy, but we had to start something at scale. So that's why we chose the live pigs to do this with. As you can see, there are over 9 or 10 different types of sensors. 4 of those are actually moving to help map the thermal results of what our study involved, which was to understand how deep can we penetrate perfusing tissues that wants to restore the body to core body temperature, and what are those implications? So as you can see here, this was a large probe on top that was a swine component, the swine version of the human version, because the bladder is much deeper in the cavity than the female, than our bladders are positioned. By the way, disclaimer, I'm not a doctor, I'm not a researcher. I am an entrepreneur, innovator for the last 35 years. So excuse me if I go over my skis a little bit. But as you can see, after we did our results on the right, we initially cut open the cavity within about 30 to 45 seconds. We're able to cool the bladder and general tissues around it as low as 26 degrees C. So in this chart, as you can see, you'll see the graphing. The lowest curves are on the actual device itself to the lower left. We have some other sensors, some radiometric sensors, which are interesting because they non-invasively sense tissue temperatures volumetrically without ever having to do any kind of invasiveness at all. So this kind of information can be very supportive in the future of future research or clinical trials. And as you can see to the lower right, you know, our bladder is for females specifically, is very close to the vaginal opening, whereas a device like this would not be appropriate. So what are the implications? This is a device that's a tampon-sized device that could be wirelessly outfitted with thermal surface sensors, passive radiometric sensors that measures that same energy that's being imparted into the pelvic cavities at depth to understand how deep and how long. The idea is to ultimately get to a commercialized device. So you ask, well, how do you know this works? Well, I, as an innovator, went a little bit over my skis and built these systems and found people on the Reddits, the Facebook, the user groups, people that reached out to me when they learned what I was doing, and they clamored for these things. And all the conditions you guys spoke about today, we've seen positive results from every one of them, which I concur, this crossover is real. So the ultimate goal of this is to create a solution, a device that's easily managed in the sanctity and the dignity of one's own home. I mean, these are very undignified conditions that we all deal with. I think you all would agree. Possibly creating a new standard of care of how everyone can treat these, the physicians. And since we can do this, this is the base system. The little probe you saw is an accessory. It sits on top. There are no electronics, there are no live electronics inside that device. It transmits that energy passively through highly conductive materials. So I just want to make sure we're clear. But this device, for a lot of conditions where it might be hypertonic pelvic floor, fistulas, fissures, hemorrhoids that are driving people crazy, it's a very good tool. And because we have the ability to connect up with the device, we actually could potentially create a telehealth type device where someone communicates with their doctor at their home as they're treating in the home, out of the hospital, out of the emergency room, where time-resolving pelvic pain is best treated. So because we can even do that, why couldn't we build a system that could potentially be utilized for clinical trials? Because we don't know everything, just like it's been discussed here. What are the implications that a device such as this could be used in decentralized clinical trials, adhering to the latest guidance from the FDA? So we're purpose designing and building these systems to be able to do just that. So it's researchers like you that could help us help you do research in this area of thermal medicine. And the only reason that I'm suggesting this is because I've shown you we can. And this is just an example of we just put in a phase 2 NIH grant. Thank you to the Wake Forest team for being willing to be part of that. We appreciate that. I don't know if the money will ever come, but if it does, it'll be great. But if it doesn't, here's my ask to you today. You can look up on hdpelvic.com. Number one, my email is at the bottom. If you like what you see today and you think that there's promise here, a simple email would be great within the next few days, just to tell me that you like what you see. Because what I need that for is I've got to be in London tomorrow morning to present to investors. Not tomorrow, 2 days from now. So it's very important these investors want to know, not only do you have people that it's benefited, but what does the scientific community think? Thank you. Thank you.
So next up is Claudia. It's actually Laura. Laura, sorry. ICA has been a great partner for many of you. Certainly gave us a start here at Wake Forest. I don't know how long ago, Steve. Was it 12 years ago, 13 years ago? Gave us the initial support grant to start us off. So it is you who tell us how well we are doing or not doing.
No pressure or anything there. All right. Well, thank you very much for the opportunity to present on behalf of the Interstitial Cystitis Association. The new leadership, by the way, of which consists of myself and my colleague, Claudia King, who is the CEO. So what we want to do is really 2 basic things today. First, we want to explicitly insert the patient voice. And then I want to highlight the importance of engaging with patient advocacy organizations like ours. So hopefully you're familiar with the ICA, but just to reiterate, we are the only national nonprofit in the United States dedicated to serving this community. We strive to accomplish our mission through 3 strategies. So advocacy is incredibly important. We were actually just on the Hill a couple of weeks ago. We engage in education of our stakeholders, and we try to create safe spaces for our community to engage with one another. I think what's really important about us, though, is our emphasis on evidence-based information. We work really hard to make sure that our patient community can make the most informed decisions they can about their own care. I'll be honest, I see a lot of anecdote being used for treatment decisions and some just straight up misinformation that we work really hard every day to combat. And we always try to bring things back to what does the scientific literature say? So I want to come to the patient voice, and I will tell you there is so much good qualitative research out there. But what I'm going to do is just give you a few direct patient quotes that I think highlight some of the things that we should be keeping in mind as we talk about consensus. So obviously, it's not a surprise to this group based on the discussion we've had over the past day that there are diagnostic challenges. It's kind of interesting to me that I've been presenting on this for a couple of decades, and 10, 20 years ago, I'd be focusing on delays in diagnosis, and that's still happening, but I think the diagnostic challenges that we're facing now, I think, have to do with the complexity of the diagnostic landscape. We've talked about comorbid conditions, confusable conditions, and we certainly see that in the quote here, that this poses a challenge for our patient community. The other thing I want to make sure to point out is that we've talked about how trauma can be a predisposing factor for this condition. I also want to point out explicitly that trauma can also be a byproduct of a painful and invasive diagnostic process if we are not careful. So even post-diagnosis, there still seems to be a lack of knowledge in the general provider community about how to put together an effective treatment plan for patients. We see this every single day in our online support community. We see patient reports of provider recommendations that I will say are interesting, to say the least. And so I want to reiterate that the lack of consensus that we have is having a direct impact on patient outcomes. I don't need to get on my soapbox. We know that this condition has a profound impact on quality of life and daily functioning. Anything from being able to go on vacation and travel with family to being able to go to work and back, sitting in a car for longer periods of time. And the other thing that I think is really interesting, a theme that I've seen in my own qualitative research, is that there seems to be this theme of pretty significant personal burden of care. And I don't bring this up to say that patients should not have accountability or shared decision-making. Complex chronic conditions require partnerships between providers and patients, but we are seeing patients take a lot of leadership in the direction of their care. And while that can be wonderful and empowering, there is also the risk that, especially for folks who are desperate or vulnerable, to seek information from less than reputable resources, to be taken advantage of, and to embark upon treatment pathways that may not only be not helpful, may actually be harmful in various ways. We all know that this takes a toll emotionally and psychologically, as this person talks about. I chose this image because I sometimes talk about feeling bent but not broken. And on a related note, but separate, I think we have to acknowledge the impact on identity that comes with living with this condition. We know that we all have lots of roles in our lives, and when you have chronic pain or you have a condition like this, you stop being able to do certain things, or you perceive that you are no longer able to do those things, as this person laments feeling less than as a woman, as a wife. And when that happens, you can feel like part of your identity is taken from you, and there is a grieving process that happens. So I say all of this just to remind everyone of what your patients, if you're a clinician, what your patients may be experiencing or feeling as they walk through the door to seek care from you. And it's just a reminder that, honestly, one of the most effective things you can do for us, at least from the get-go, make eye contact, listen to us, validate our concerns, have a little empathy. That goes a really, really long way. Now, you don't have to do all this on your own, though. And so I do want to point out that as a patient advocacy organization, we can help. So first and foremost, just referring patients to us. We're going to debut a really nice new little prescription referral pad at AUA. Stop by our booth, by the way. Get them to us. We can absolutely help them build out a multidisciplinary provider team through our provider registry. We have support group listings, and we curate timely, relevant, and evidence-based education for our patients. I also want to say that we can help with lots of other things too. We've been talking about clinical trials, study design, patient registries. We absolutely can help. If you want the patient perspective in your study design, come talk to us. We can help with things like patient recruitment and retention. Importantly, we already help with recruitment because of our patient network. I have researchers coming to us, usually after they've gotten IRB approval, and they send me their recruitment flyer and just give me a little aside here. I'm going to implore you to please stop putting images of women grabbing their crotches on recruitment flyers. There are better visuals. We can help you with that, okay? In addition, we can also help you with dissemination and translation of key study findings, and I happen to believe that we should absolutely be involved in the co-creation of educational materials that represent consensus findings that also incorporate the patient values and perspectives. Finally, I just want to say that you as clinicians and researchers, you all have a microphone that we don't have all the time as patients and patient advocates. Please use it. We have now more than ever have a need for both an amplified and collective voice around research funding, especially around the CDC and NIH. And if you want to be engaged in the ICA's advocacy work, please reach out to us. We would welcome you with open arms. Thank you.
That was outstanding.
Sorry.
We are on our last legs now. Stay with us. And these are going to be the summary slides. We're going to go slightly out of order. The Therapeutics Committee needs to present first because Karis needs to leave. So let's bring that up, please, if you...
Hello, I'll be presenting on the update on therapeutic treatments. Just an overview, ICB-BPS is a chronic condition, and we present several interventions for treatment of ICB-BPS, including conservative therapies, oral medications, immunotherapies, intravesical therapies, neuromodulation, and then finally investigational therapies and novel intravesical drug delivery systems. For conservative therapies, we include dietary and fluid management, particularly in patients with dietary triggers and frequency, pelvic floor physical therapy, and cognitive behavioral therapy. We suggest a multidisciplinary treatment team that can address all of these aspects and that can include psychology, psychiatry, pelvic floor physical therapy, among other clinicians. For oral medications, we present pentosan polysulfate. That is the only oral medication that is FDA approved for ICB-BPS. Additionally, we suggest tricyclic antidepressants, antihistamines, and cyclobenzaprine. That is particularly useful in patients with widespread pain, alongside other systemic agents. For immunotherapy, calcineurin inhibitors can be helpful. Cyclosporine is helpful in patients with Hunner's lesions, and tacrolimus is helpful in patients with intractable ICB-BPS and can be administered intravesically. Intravesical therapies include cystoscopy with hydrodistension, as well as cautery. Additionally, we present medications that can be administered intravesically, including DMSO, lidocaine, glycosaminoglycan layer substitution therapies such as heparin, botulinum toxin, and myofascial trigger point injections we included under the intravesical therapies. However, that's mostly for patients that have tender trigger points on pelvic floor exam. Neuromodulation also can help with some pain management as it blocks C fiber activity. Future investigations are limited due to some of these limitations, such as small sample sizes, heterogeneous patient populations, and lack of standardized outcome measures. However, we did identify some promising investigative therapies. These include low-intensity shockwave therapy, platelet-rich plasma, VEGF inhibitors, gene therapy, enzyme inhibition, monoclonal antibodies, and some cannabinoid receptors, as well as novel intravesical delivery systems. Those include catheter-free delivery systems, thermosensitive hydrogels, and liposomes. Thank you.
Okay, so next up is diagnostic criteria. Glenn's left that talk to Clinton.
Which one is it? Diagnostic summary. I asked Glenn to do it, but he refused. I'm just kidding. So what I did is basically took the feedback and summarized it here so that I'd prevent, and then what we'll do is take our longer presentation and narrow it down to 5 minutes. And I anticipate that just having this as the last slide to understand that we will potentially make a few adjustments. We will make a few adjustments. So the feedback we got about our area was be sure to have adequate details about the diagnostic workup. So while we focused on
how to make the diagnosis. There's also certain things like making sure to be clear about how you do rule out some things like neurologic conditions, like pelvic floor dysfunction, vulvodynia, tests and things that can be done along those lines. And to, highlight that ruling out some conditions sometimes can require a multidisciplinary approach. And there was also feedback that while questionnaires don't make the diagnosis, it's very important to gather that data at baseline so that then it can be used to track symptoms and response to therapy over time. Then I think that there's this concept of the role of cystoscopy and when to do it. I certainly seem to be no problems with the idea of saying that a diagnosis requires 3 months of symptoms. And so it may be that we say that, once the patients get to that point where it's really looking like more of a chronic situation, that if they haven't had a cystoscopy, that would be a reasonable time to do it. I'm not sure we're going to say every patient needs a cystoscopy from the beginning, but I think we will certainly highlight that that's something that eventually all patients should have if they haven't responded to therapy, certainly. Also, then there was feedback about ensuring adequate details about urine testing. Certainly if there's hematuria, that should be worked up. And in general, some patients already have had multiple urine cultures, means we don't need to repeat that, but others who haven't had an adequate assessment, it makes sense to do. And then there was just definite, feedback that, there are certain tests that in certain parts of the world are routinely performed as part of the diagnosis. And while it's not necessarily something in a consensus document that we're going to recommend, to at least acknowledge that there is heterogeneity and perhaps constantly it's nothing wrong with doing that, it's just there are some differences in how it's done. So that was kind of the main themes or comments that I think we got.
Next up is disease phenotyping. Oh, I know this guy.
Thank you, Maddie. Hello again. We're presenting our basic slides that we'll be giving at the AOA with some expected annotations as we go along and incorporating the feedback from the group on how to restructure things a little bit. So our basic introduction, Thank you. There's a significant heterogeneity of symptoms and syndromes. Stratifying patients by phenotypes should help enable more targeted and effective therapies and improve our understanding of variable pathophysiologic mechanisms. We performed a primary literature review with a special focus on 12 pre-selected areas as well as all phenotyping efforts. We're grouping patients into bladder-centric groups that have symptoms focal to the bladder, as well as identifiable characteristics, systemic groupings such as widespread pain and other systemic syndromes, as well as the variable regions that can't easily be fit into either of these groups at this time. To start off with bladder-centric, we have the clear Hunner's lesions. No one is going to be disagreeing that this is a separate phenotype. We require cystoscopy to confirm diagnosis. It's well described previously with older age. Worse urinary symptoms, less widespread pain, and fewer chronic overlapping pain conditions, and their own specific treatment regimens. Next up, anesthetic bladder capacity. As can be seen with molecular targeting, we can see that patients group together whether or not they have Hunner's lesions or whether or not they have a low anesthetic bladder capacity, and all patients with Hunner's lesions group together. And this also maps closely with having fewer chronic overlapping pain conditions, older age, higher IC symptom scores, and incorporates most patients with Hunner's lesions have a lower bladder capacity. And this is in contrast to the systemic group with more chronic overlapping pain conditions, a younger age, lower symptom scores, and very rarely have Hunner's lesions. Based on the feedback from the group, we are not ready to put all bladder-centric patients into one group, but think that they are closely aligned. Future research should be identifying if these patients truly are the same grouping or similar but closely overlapping. This is in contrast to the systemic grouping, which, as we already discussed, has more overlapping pain conditions, less severe urinary symptoms, and is most closely aligned with the widespread pain being a clear delineator. The MAP network has done extensive analysis showing that patients have chronic pain beyond their pelvis. This is stable over time, and many patients are associated with other symptoms such as more chronic overlapping pain conditions, worse somatic symptom scores, psychological symptoms. This is important due to treatment efficacy differences by systemic medications being given to patients with widespread pain seeming to be more effective, whereas those with less widespread pain are more effective with bladder-centric treatments. And there's going to be the ATLAS study, which comes out any day now, which we can add to our discussion on this as well. Next up, the more variable metrics that don't easily fit into either of these two categories. The infection phenotype, recurrent UTIs is a promising area of research that may be able to be treated with a vaccine. Further research is needed, though, as we don't truly understand what level this underlies. And then the myofascial pelvic pain, or as Dr. Lai easily summarized for us this morning, the pelvic floor centric. This is an interesting area where there's patients with more tender regions tend to have more systemic presentations, but then it's also notable that patients with Hunner's lesions in the MAP analysis had equal levels of having any amount of myofascial pelvic pain. So these groups are very important in that they respond well to pelvic floor physical therapy and should be identified. It is also possibly an area of an exclusionary diagnosis if you treat this and all their symptoms go away. Potentially it was never a bladder symptom at all, but just pelvic floor physical therapy or myofascial pelvic pain that needs to be treated. And so in summary, these are our three main groupings. And we have non-mutually exclusive phenotyping with four major groups, those with Hunner's lesions, those with the low anesthetic bladder capacity, widespread pain groupings, and the pelvic floor centric group. And we note that there's other additional clinical features that we'll be discussing in more detail that don't easily fit into a clear diagnostic criteria, but can help guide people across these and require more research, such as inflammation, chronic overlapping pain conditions, psychological changes, recurrent UTIs, and things like bladder filling pain. Thank you all.
So next up is disease markers. Dr. Ackerman, thank you.
So everybody's plane flights left me with this to discuss, so I'm going to start off with Henry's slide that he's shown a bunch of times. I like this a lot. And mostly I wanted to show this just to reinforce some of the feedback that we got about trying to place the context of biomarkers that are abnormal in patients with bladder pain into sort of to try to go beyond just the like, oh, we did a bunch of studies and we found some biomarkers were elevated, to actually try to relate that back to disease phenotyping, potentially prognostic and diagnostic phenotyping, and how that might relate to etiology. And so kind of put those, what we do have data for, into a bunch of different categories that relate back to some of the ideas about the etiology of the disease that we have. So the idea that maybe there's an autoimmune version of this disease, maybe that corresponds with Hunner lesions. There's fibrotic markers, markers of urothelial damage and changes in the urothelial barrier function, neurogenic inflammation, other types of chronic inflammation and tissue damage, and then the question about oxidative stress. So this is just kind of a big overview of some of the things that have been found in a variety of studies and how we might sort of subcategorize them to relate back to potential disease mechanisms. And then what there is a little bit of data for, but not a lot of, is trying to figure out kind of how this might relate. And I think this is where my squiggly marks here are really just to explain what my brain goes through every time I read these, which is that I think there's still a lot of questions about how to utilize these markers and what they really tell us about bladder pain syndromes and what we still need to do. And so just as another sort of layer to this, what we intend to add in our description is not only sort of a better exploration of some of these categories, but also a little bit of guidance for how to move forward. We talked a little bit as a group about the idea that we could establish a panel of biomarkers that we should be looking at, so that we can come to consensus between different sites and not everybody is looking at different markers and claiming they have the only marker that is the right one, and also a set of guidelines for how to collect biological samples from these patients so that samples are comparable, and that if we come up with these things in the future, we have the ability to validate them at other sites or with other data sets. And so I think that's kind of the feedback we got. Happy to entertain any more if anybody has anything else they want to add. Thanks.
Great. The etiopathology is next, and I think Larissa is presenting that.
I first want to apologize. I just heard I was presenting this, and it's the first time I see the slides about 15 minutes ago when Henry said I'm out of here. So I'm going to go quickly because it's a little bit redundant with what we have been talking about over and over and other groups, and I think it's something that hopefully we will also address. It is basically bladder-centric or systemic, our phenotype with this potential of pelvic floor-centric. And again, these are the slides that Henry is planning to present at the AUA. With the, as mentioned before, different therapies for widespread pain, worse prognosis, worse symptoms, and the role of toll-like receptors as well as systemic options. With the Honner's ulcer and low capacity as bladder-centric phenotypes. I think this figure is missing everybody else. You know, we have a lot of patients that do not have Honner's ulcers, do not have low bladder capacity, and do not have a widespread phenotype. And it's kind of missing from this. I will let Henry know and see how we integrate that into the talk. He's planning to present some of the histopathology of Honner's ulcers and maybe being more of an immune type of response with this clonal B cells having an important role. Mentioning the IgE in the bladder tissue of some patients that is similar between Honner's ulcers and ketamine cystitis, but really not significantly present in patients that do not have Honner's ulcers. Interestingly, 20% of controls have this, which I think it is quite significant, but as a potential of an antigen or some immune response that is present in patients with Honner's ulcers. The low bladder capacity was just described very nicely, very similar, the 400 cc's predicting relief after cystectomy, 500 cc's kind of predicting worsening symptoms, and the high bladder capacity being more likely to have comorbid depression, irritable bowel, and endometriosis. The role of widespread pain between being bladder only to intermediate and high levels of multiple areas of pain, and how this kind of widespreadness leads to increased symptoms, other comorbidities like fatigue, difficulty concentrating, worse sleep disturbances, and really overall worse quality of life in these individuals. And the role of TLR4, which Andrew is here, some of you can talk to him, in maybe being a marker or maybe even a mediator of widespread pain in these patients. We didn't speak a lot in this past couple of days about neuroimaging. You know, we have spent a lot of efforts in neuroimaging of this patient population. I think this data where the supplemental motor area as well as the salience network have been shown to somewhat predict or divide individuals that have localized versus intermediate or widespreadness in pain is really interesting. And how kind of the treatment, which this has mentioned in a number of talks, can be different between these two phenotypes. This is the beginning of the slide and a summary. I had one more slide, I guess it wasn't there, that didn't make it to a presentation, but since I'm here, and I think I have a number of things that I wish we as this incredible group of experts will address. You know, one of them is the question I think that Ken had, is this widespread condition really IC, or is this the bladder just one of many organs that are being affected in individuals who have centralized pain? And are we doing a disservice by grouping it together, or is it really just IC with kind of bladder-centric and systemic? I think I don't have an answer, but I think it's worth a discussion. You know, we have spent a lot of money on MRIs. What can we do to really modulate the brain and the areas that we have found? I mean, we are doing RTMS. I know Mauro is doing some of that as well in his practice. Can we modulate the areas that we have found in neuroimaging, and would that be effective in the bladder of individuals? Going with the talk, the excellent talk from Laura about patients do a lot of self-management, an awful lot of self-management. Why don't we study that? You know, it's probably more effective than any drugs that we have talked here or therapies that we're doing here, and have less side effects. You know, in the same vein, you know, we all kind of giggle with the placebo effect. The placebo effect is a neurobiological effect. Why don't we find ways to enhance that? You know, if again, will have less side effects, and it might be even more therapeutic than many of the things we do. So I know there are no clear answers. That's not going to be presented at the AUA, but I thought given this audience and that it might be ways to communicate if anybody's interested in any of those things. I'm really interested in stress, another of those things that we talk about it for 30 years. Stress makes symptoms worse. Why are we not focusing more on that? Or the comorbidities that affect? If we treat depression, is the pain better? Can we be treating other things that are comorbid, psychosocial things that are comorbid on patients to really improve symptoms instead of being so focused on therapeutics? Thank you.
So your input in the survey questions would all be helpful. So if you have ideas that we should include in survey that's going to all of you, would be helpful to formulate some questions, because we won't do it individually, do it as a group. So the male group, are you ready? Or you have your slides up? Yeah.
So we just had the discussion yesterday at length, and there's nothing much. I've added a few things, but of course, since it was a summary, I brought out a few of the slides that we presented yesterday. And most important is that the ratio of male to female is different from what we were taught when we were reading about it. And it is how the difference between the diagnosis is primarily because of a physician bias and failure of effective treatment in men compared to women of ICBPS is primarily due to the care provider bias, and that is an important fact that we need to drive. And in a recent study, as Sanjay Sinha yesterday pointed out, that whatever presents as LUTS, if you subject them to ICSI, they come up with pain as part of their LUTS, which they would not otherwise come up with. And men, being men, they would report less of pain as compared to others. But when they complain, then they really complain of pain only, and not a diffuse disease. Of course, the urological CPPS versus bladder pain syndrome, the basic crux of differentiation is relationship with micturition cycle, which we emphasized and discussed yesterday. And of course, the clinical features, there are not many differences, except that when the men complain of pain, it is pain. More pain, localized pain, rather than a widespread pain. And obviously, there was a discussion about the technique of DRE, tenderness and myofascial bands in the pelvic muscles that may suggest overactive pelvic floor. My only concern is that we need more evaluation and literature support on this, because a man who has a pelvic floor spasm, how easy or difficult it is for you to do a digital rectal examination and complete all that, what we've been discussing even today. And the differentiator between the prostatitis and ICBPS has to be clear, and we presented yesterday. I'm not going to repeat it. And there could be a role of lignocaine test, only time will tell. Obstruction in men could be related to BPH or strictures, and they need to be treated as per their merit. PSA, as Dr. Badlani pointed out, that a negative PSA may help exclude prostatitis. We will need to have a literature support, but we can put it in our manuscript nonetheless. And as I mentioned, if there is a concomitant obstruction, urodynamics may be required as per the requirement of the case, and you must consider treatment of an outlet obstruction to reduce the symptoms. And more, this is what we discussed yesterday. Thank you so much.
So Next up is genomics and histopathology. Professor Akiyama.
Oh, sorry, you saw it. This one, summary.
I found it. Yeah. It is short summary. Summary. Okay. Thank you. Okay. Thank you. So this is a short summary for the genomics and histopathology subcommittee, and the ICBPS umbrella is categorized into the Hanna region disease and non-Hanna region subtypes. And the Hanna region disease is distinct inflammatory disease, and non-Hanna region disease should fall under the BPS umbrella. And the etiology of the non-Hanna region disease may be the urothelial alterations, or bladder fibrosis, or small bladder capacity, or widespread pain, etc. And the Hanna region disease is histologically a distinct inflammatory disease and characterized by the dense lymphoplasmacytic cell infiltration, epithelial denudation, neovascularization, and pancystitis, which means similar inflammatory changes can be observed in the background mucosa. While a non-Hanna region disease, and also referred to the bladder pain syndrome, is histologically a non-inflammatory disorder, even though the mild inflammatory changes can be seen in some of the non-Hanna region disease phenotypes. So the Hanna region disease manifests a moderate to severe lymphoplasmacytic cell infiltration, while non-Hanna region disease shows a subtle to mild lymphoplasmacytic cell infiltration. Also, the epithelial denudation, the Hanna region disease shows as a completely full layer denuded epithelium at the Hanna regions, and the partially denudation at the non-Hanna regions. That means why the Hanna region seems reddish. This is a subepithelial granulation tissue we are seeing at the Hanna regions. But the other non-Hanna region area, some epithelial layer are still remnant. So that's why the mucosa seems like normal bladder mucosa. And meanwhile, the non-Hanna region diseases, the epithelium is preserved, and we can see the umbrella cell and the superficial layers. As for the mast cell density in ICBPS, yes, mast cell plays a very important role in the etiopathology of ICBPS, but the quantitative analysis of mast cell density in the diagnostic value is skeptical, because as shown in this slide, mast cell density is increased only in the Hanna region, maybe which is accompanied by the lymphoplasmacytic cell infiltration. And the non-Hanna region diseases, the mast cell count is equal to the normal bladder tissues. And also the gene expression profiles are distinct in the Hanna region disease and the non-Hanna region diseases. So we can see the distinct histology between the Hanna region disease and non-Hanna region disease in the lymphoplasmacytic cell infiltration, mast cell infiltration, and epithelial denudation. So based on these genomic pathological data, we can see the pathophysiological implications for the etiopathology of ICBPS. For Hanna regions, so some type of the Hanna region disease may be an immune-mediated inflammatory disease of possible autoimmune nature, suggested by the clonal expansion of infiltrating lymphocytes. I forget to explain about this figure. So this figure means the immunogenomic data of the TCR, T-cell receptor, and the B-cell receptor. So specific BCR or TCR clone coronary expanded in the Hanau region cystitis bladder, and also the presence of the genetic risk variant in the MHC class 2 genes suggests the possible autoimmune nature of these diseases. And for the non-Hanau region diseases, the mast cell may play an important role in combination with hyperinnervation of the sensory nerves in the bladder tissue. This may be the etiological role, play an etiological role in the bladder-centric phenotype of the non-Hanau region diseases. And also the increased fibrosis may be important in the non-Hanau region disease bladder-centric phenotype, as shown by this slide. So I summarize from the genomics and histopathology of ICBPS. So histologically, Hanau region disease is a distinct inflammatory disease. And some of the Hanau region disease may be associated with dysregulated autoimmune responses. Meanwhile, histologically, non-Hanau region disease is not an inflammatory disease. So quantitative analysis of mast cell infiltration and urocellular residue may not be variable in the diagnosis of ICBPS, but the functional dysregulation of mast cells accompanied by increased fibrosis and alterations of urothelium or dysregulation of urothelia, as suggested Professor Parsons in this meeting, may be associated with the etiopathology of ICBPS. Thank you.
I think it's the patient-reported outcomes. Next. I was informed that many of you either missed or didn't receive the email with the zip drive that had all the 10 documents in it. So if you haven't received it, let Carolyn know, because I looked and it was sent. I forwarded it to Larissa. I don't know whether you received it this morning. I forwarded it to you. Please look at those documents. You know, there was meant to be before, but Curtis.
Thanks. Claudia King, our patient representative, is going to present the summary at the AUA, and that to me is only appropriate for patient-related outcomes to be reported by a patient. We'll have slides for Claudia then, but I have none now. I'm tired of slides after a day and a half, tired of seeing them, tired of presenting them. So our group, as you know, the consensus group on PRO went through a literature search in which we summarized all the presently used PRO measures, a description, their validity, and the pertinent references. We then developed areas of interest and concern and put together 4 critical PICO questions, which we answered and came up with consensus recommendations, which we presented yesterday. The major recommendation is that we need to develop better patient-related outcomes for use in clinical practice and clinical trials and studies. There are some out there that are reasonably well validated, and we can use those in clinical trials and practice at the present time. For primary endpoints, unfortunately, all we have available, and this was discussed by other groups, is the 0 to 10 pain score, voiding diaries, and possibly the global response assessment. As far as secondary endpoints in clinical trials, the most important would be the global response assessment, the O'Leary-Sant for possibly anchoring the trials against historic clinical studies, and we believe at this point the best validated, and not perfect by a long shot, and we'll have that in the discussion in the paper, is the NIH Genital Urinary Pain Index, one for men and one for females. As far as other generic, we talked about quality of life, pain inventories, and we also believe that psychosocial parameters should be examined, but selectively in clinical trials and studies. For clinical practice, we would like to see individual patient-related outcomes being discussed with patients and their therapy and outcomes directed by individual PROs because of the heterogeneity of the disease. If you can't do that, then we believe that the two reasonably validated questionnaires that can be used in clinical practice would be the NIH Guppy or the pain urinary frequency questionnaire. More work is needed, and we really do believe that we should put more time, effort, and resources in developing a true patient-related outcome, and it may be different for the different phenotypes, so it will be a major task for somebody here to start. Thank you very much.
I think the gynecology group is next. And then finally, the registry. Did I miss anybody else? Maria, are you doing the gynecology group?
Okay, thank you, everyone. So our objective was to evaluate the role of gynecologic findings in ICBPS by reviewing current international guidelines and identifying relevant gynecologic comorbidities. Our methodology was that we did a literature review, and then our 6-member multidisciplinary expert panel came together to form a consensus. It was modified yesterday afternoon after all of your feedback, and we are now preparing our manuscript. We found that a number of associated gynecologic disorders may overlap with ICBPS, and our consensus committee identified the 5 main comorbid disorders to be endometriosis, genitopelvic pain disorder and sexual dysfunction, as well as overactive pelvic floor muscles, genitourinary hormonal changes, and vulvodynia and vestibulodynia. To start with endometriosis, we know that the overlap is about 65% in patients with ICBPS. Genitopelvic pain disorder, the overlap is about 75% of women with ICBPS. For overactive pelvic floor muscles, we find that as many as 85% of women with ICBPS are diagnosed with overactive pelvic floor muscles. And as we reviewed yesterday, we have the biomedical perspective as well as the biopsychosocial perspective that leads to this vicious cycle of pelvic floor pain. Genitourinary hormonal changes are also very influential. ICBPS symptoms can fluctuate in relation to the menstrual cycle, pregnancy, lactation, exogenous hormone use, and or menopause. So hormonal deficiency must be corrected. Vulvodynia and vestibulodynia is also concurrent with ICBPS. Really, this ranges based off of the diagnosis, but can be 25 to 85% of our patients. These are conditions that cause chronic pelvic pain, but are not sufficiently related to ICBPS. So we decided as a consensus group that we are not going to delve into detail in our consensus statement. We will just mention that they are exclusionary diagnoses that we must be aware of, but are not our 5 main comorbid diagnoses that we decided on as a group. This consensus highlights the most prevalent gynecologic comorbidities supported by the current literature. We strongly believe evaluation of patients should prioritize a detailed pelvic exam to identify these overlapping conditions. Future directions include developing a multidisciplinary diagnostic and treatment algorithm to guide clinicians in comprehensive ICBPS care. Thank you.
Great job. That was a great summary. The last is the ICBPS registry or data site outcome. Where are you going to find your talk?
It's here.
All right, thank you guys all again. These are not going to be representative of the slides presented at AUA, but we've sort of incorporated everybody's feedback from yesterday to highlight how we plan to address that in our manuscript. And then Amy Dobrafel will be presenting at AUA, as I will not be there. So regarding the inclusion in the registry, I know there's been a lot of talk about, apples and pears being in the registry, it being, a more homogeneous thing. We'll link up with the diagnostic subcommittee to kind of, finalize this inclusion criteria. But for now, we're kind of keeping it as they have already defined, and then, to be determined how we end up changing that. And then based on feedback we got yesterday, just looking at demographic details to make sure that, especially when we're focusing on gender identity and then sex assigned at birth, not siphoning people into just male and female. So just we will keep that in mind for a registry. And then I highlighted here that we would include family history, as Kaylee pointed out yesterday. That's an important piece to kind of the history of the present illness. Looking at the symptom questionnaires, the PRO committee, we're going to be linking up with them to make sure that we're standardized with that, but highlighting just the ones that were mentioned yesterday as being important. I crossed out some of the things we had on the slide, added the 7-point GRA, and then highlighted the other important things to include, such as the GUPI, the O'Leary-Sant, PUF, I think we were up in the air on that one, but the visual analog scale, and then the GRA. And then finally, I think probably one of the more challenging things is the actual the logistics of having the registry. So what platform will it be housed on? Is it going to have sponsorship from an organization? And then how do you finance it? So just like what Dr. Bidlani pointed out yesterday, thinking about the AUA's sponsorship of the Aqua registry, and then the fact that Wake Forest University already has kind of like a small registry of the patients that we've been looking at here. And so just thinking about what registries already exist, can we sort of combine registries to start this registry? And there's just a lot to consider with the funding. So I'm sure that will be something that we work out over the next several months to a year, as Dr. Bidlani pointed out. All right, thank you guys.
Great. So I know there's been a lot of redundancy by chance or design, but it was meant to sort of highlight what we were going to say at the AUA, and that's why this session was done. So first of all, I have to thank all of you for being here and participating, and I hope you will continue as a group to participate in our formal activities. So my plan, as I've mentioned to you, is a survey. Manuscripts are due May 19th. You will update, and please drop off these forms so we can set the reviewers after the manuscripts are submitted, and then hopefully we can get them published. I really have to thank all the people. Chance out there, shout out to him. Ramesh, whose team has been recording everything. We have to think about what to do with the recordings and how the website will continue. If we're going to put material on it, I'll have to restrict access. It's currently an open website. So in that survey process, we'll find out how we should sort of restrict access to the videos, the talks, and survey information, et cetera. I don't want to form another society, so it'll have to be something else. A process. And then, of course, Carolyn and Kaylee sitting out there have done a great job, so another round of applause to them. All the junior researchers will continue to work to polish the manuscript to submit, because all the big chiefs will go back to seeing the patients. Please check out, in a timely manner, those who are just leaving today. The W-Form tour will start at 12, meet in the lobby. Is that good? Yes. And all of you have the shuttle information. I look forward to seeing you at the AUA, at the SIU session. Oh yes, thank you. Can we all collate at the steps to take a picture? Ramesh is going to take a picture, so please stand on the steps. So please, as we can step that, and Last but not least, once again, thank you to all of you. We'll end the session. Please stand and take a picture.